Bradley and I will be presenting on porphyrias, and we will be focusing on the disorder in the pediatric population. Listed here are the objectives for the presentation. We will be describing the pathophysiology of porphyria. We will be discussing aminolevulinic acid synthetase, also known as ALA synthetase. Next, we will describe acute intermittent porphyria, along with the signs and symptoms. We will review various triggering agents, as well as how to treat acute intermittent porphyria. We will discuss various drugs while focusing on common anesthetics that are safe and not safe in patients with known porphyria. Lastly, a case report will be presented on the use of ultrasound-guided regional anesthesia in a pediatric patient with known porphyria. Porphyrias are a group of metabolic disorders that result from the deficiency of a specific enzyme in the heme synthetic pathway. The pathway involved in the production of porphyrins is determined by a sequence of enzymes. So any defect in these enzymes can result in accumulation. Porphyrias is characterized by an overproduction of porphyrins. So an overproduction and accumulation of porphyrins produces a form of porphyria, and we will be discussing the different types of porphyria and the importance of understanding the pathophysiology in this disorder. Heme plays a major role and is the most important porphyrin and is bound to proteins to form hemoproteins. These include hemoglobin, myoglobin, and cytochrome P450 isoenzymes. Porphyrins are essential for hemoglobin function. They are necessary for oxygen storage and transport to vital organs and tissues. The production of heme is regulated by the activity of aminolevulinic acid, ALA synthetase. It is important to understand the role of ALA synthetase in order to understand the disorder. ALA synthetase is an enzyme involved in the rate-limiting step of heme formation. The endogenous concentration of heme controls the formation of ALA synthetase. The formation of ALA synthetase is controlled by a feedback loop, and this feedback loop ensures that there are sufficient levels of heme production in relationship to the demand. ALA synthetase is readily formed and available to rapidly respond to increased heme requirements. Examples of this are drugs that need cytochrome P450 isoenzymes for metabolism. So in the porphyria disorder, when there is an increase in heme requirements, an accumulation of pathway intermediates develop. There are many different types of porphyrias, and porphyrias are classified depending on the primary site of overproduction or accumulation of the precursor of porphyrin. They are classified as either hepatic or erythropoietic. Examples of hepatic porphyrias include acute intermittent porphyria, variegate porphyria, hereditary coproporphyria, and porphyria cutanea tarda. Examples of erythropoietic porphyrias include congenital erythropoietic porphyria and erythropoietic protoporphyria. They can be additionally classified as acute or non-acute porphyrias. We will be focusing on acute porphyrias since they are the most relevant to the management of anesthesia and can be exacerbated by certain drugs that we administer. The inheritance pattern of porphyrias can be either autosomal dominant or autosomal recessive. Porphyrias that fall under the autosomal inheritance pattern include acute intermittent porphyria. Most cases of erythropoietic protoporphyria will fall under this autosomal dominant inheritance pattern. Hereditary coproporphyria, variegate porphyria, and porphyria cutanea tarda. And I'll quickly go over different effects that these have on individuals. So the acute intermittent porphyria affects the central and peripheral nervous system and produces the most serious symptoms. For erythropoietic porphyria, they may develop photosensitivity and edema. And then for hereditary coproporphyria, this one is less common and patients experience neurotoxicity and cutaneous hypersensitivity. And then for variegate porphyria, This one's rare and is characterized by neurotoxicity and cutaneous photosensitivity. And then for autosomal recessive porphyrias, these include congenital erythropoietic porphyria, ALA dehydratase porphyria, and some cases of erythropoietic protoporphyria. So for congenital erythropoietic protoporphyria, you may see hemolytic anemia, bone marrow hyperplasia, and splenomegaly are often present. And then ALAD is a rare porphyria. For the autosomal dominant, a single mutation can be enough to reduce the activity of the enzyme needed for production of heme, which will increase the risk of developing these signs and symptoms of porphyria. And then for autosomal recessive, the patient may have the gene but may not show signs or symptoms. So this can also be described as a latent porphyria. So you may see that they have the gene and have the disorder but don't show signs and symptoms. Acute porphyria can be precipitated by events that decrease heme concentrations. This causes an increase in activity of ALA synthetase, which stimulates the production of porphyrinogens. Acute porphyria attacks are rare before puberty. And there's no direct influence of gender on the pattern of inheritance, but is more common in females than in males. Enzyme-inducing drugs are the most important triggering factors. Acute porphyrias can be precipitated by hormonal fluctuations, fasting, dehydration, stress, and infection. Acute porphyria is the most relevant in anesthesia management and can result in life-threatening reactions in response to certain drugs. It's important to note that these factors, fasting, dehydration, and stress, are all related to surgery. Patients are NPO for hours, so they're dehydrated, they've been fasting, and just the stress on surgery alone can cause an acute porphyria attack.
Okay, so acute intermittent porphyria is the most common type of porphyria that you would see as an anesthesia provider in the operating room. So it's pretty important to understand what this is and recognize the signs and symptoms that are associated with this. So acute intermittent porphyria is an autosomal dominant deficiency in porphobilinogen deaminase, which we covered, that can manifest as a sudden, possibly fatal neurovisceral crisis. Some of the symptoms include abdominal pain, seizures, respiratory and limb weakness, hypertension, and tachycardia. In some rare occasions, acute intermittent porphyria may present with symptomatic hyponatremia secondary to SIADH, acute pancreatitis, or spontaneous hemothorax. Different triggers include fasting, stress, dehydration, and medications that we will cover. So some of the signs and symptoms of acute intermittent porphyria, besides what I just covered, you would see severe abdominal pain. That's in an awake patient. If they're asleep, obviously, you could see signs and symptoms of pain, such as tachycardia and hypertension, hypovolemia, ANS instability, hyponatremia, like we covered, seizures, upper motor neuron lesions, and cranial nerve palsies. But the most lethal neurological manifestations come from the skeletal muscle weakness that progresses to quadriparesis and leads to respiratory failure. So triggering drugs. Certain drugs, anesthetic drugs, are known triggers of acute porphyria. They do this by inducing the activity of the ALA synthetase. They interfere with its negative feedback control at the final common pathway of heme synthesis. Only the acute forms of porphyria are actually affected by the drug-induced enzyme. Potent enzyme inducers of ALA synthetase, such as anticonvulsants, do not exacerbate or precipitate non-acute porphyrias. Stress and sepsis during the perioperative period make it difficult to determine the potential of anesthetic drugs to cause porphyria. So these are some of the drugs commonly used in anesthesia and whether or not they are safe or not. in someone that has a known history of acute intermittent porphyria or has had genetic testing and they're susceptible to porphyria. So as you can see, our volatiles are safe. IV anesthetics, it says to avoid thiopental, methotrexate, etomidate, and ketamine are the two big ones. For the most part, sedatives are safe. Analgesics, avoid Toradol. Your neuromuscular blockers are safe. Opioid antagonists are safe. Reversals for the neuromuscular blockers are safe. And then for the cardiac meds, you want to avoid amiodarone and calcium channel blockers. And all of your local anesthetics are considered safe as well. So perioperative assessment for someone that has porphyria. So porphyria is kind of like MH in the sense of a lot of patients won't even know they have it unless they have a known family history or they've had previous genetic testing that has let them know that they have a genetic link to this disorder. So it may be a little bit difficult in the preoperative arena to assess someone that has this. Like I said, unless they have a known family history. Um, Under general anesthesia, like I said earlier, you might see hypertension and tachycardia, so it might make it a little bit difficult to diagnose, but you would want to keep this in your mind as a differential diagnosis when you see this in the operating room. So how do you manage these patients in the operating room? We already went over what was safe and what was considered not safe for drugs, so that's definitely something that you would want to take account and avoid those drugs that are known triggers for acute intermittent porphyria. You also want to identify susceptible individuals. So if someone notes that their family, one of their family members died under anesthesia, it would probably be in your best interest to ask more questions about if they knew what happened or what caused it. So the first thing would obviously being able to identify and then determine the drugs that you're going to use and if not, their triggers. And then if an acute exacerbation is suspected during the perioperative period, it is important to pay close attention to the skeletal muscle strength and cranial nerve functions. These are signs that may predict impending respiratory failure and increased risk for pulmonary aspiration. You want to assess your fluid balance and always keep your electrolyte status in check, especially hyponatremia. Aspiration prophylaxis can include PPIs and our H2 receptor blockers. It's a good idea for these patients in case they do have respiratory failure, and which would increase the risk for pulmonary aspiration. You would want to let them know that postoperative mechanical ventilation may be required if they are weak, so that's something you would want to include when you're doing your preoperative assessment and when you're getting them to sign the consent. And then current evidence supports the use of benzodiazepines for preoperative anxiolysis, so those are safe. So general anesthesia, the IV induction drugs are the most dangerous medications for a patient at risk for acute porphyria, so you want to avoid barbiturates, etomidate, and ketamine. Propofol is the drug of choice for induction of anesthesia, and then as midazolam, narcotics, and Precedex are also safe. Nitrous is safe, and all your inhaled anesthetics are safe. And then obviously with these, you'd want to monitor for signs of autonomic dysfunction and blood pressure changes, especially hypertension. So the treatment, if someone is having an acute intermittent porphyria crisis, so obviously the first thing you would want to do is remove the known triggering agents, just like MH. Like I said earlier, it might be hard to diagnose this right away unless you know that the patient has this and starts experiencing symptoms. So it's kind of going through your differentials and being able to diagnose this. But if you are able to diagnose this, you obviously want to remove the triggering agent, provide adequate hydration and electrolyte replacement. You'd want to treat their pain with opioids because those are considered safe. Antiemetics can be administered for nausea and vomiting. You can treat the tachycardia and hypertension with beta blockers, and seizures can be treated with benzos or propofol. And then all patients during an acute attack receive heme therapy immediately. Heme is administered as hematin, heme albumin, or heme arginine. These forms of heme supplement the intracellular pool of heme and suppress the ALA synthase activity via the negative feedback loop. From my understanding, this drug sometimes, especially in smaller hospitals, has to be flown in from other hospitals. So it's kind of important to know if this drug's available if you're doing a case with someone that has a known genetic link or porphyria. And recovering following an acute attack is dependent on the degree of neuronal damage as well as the respiratory damage and if they have respiratory weakness. And the recovery is usually rapid if treatment is started earlier. So it's kind of treated the same way as MH in the sense of as long as you treat them, most people will recover. So, case report. So, porphyria in pediatrics, as far as case reports go, is extremely hard to find a specific case report that zoned in on pediatrics, but I was able to find one specifically that talked about ultrasound guided regional anesthesia in a pediatric patient that had acute intermittent porphyria. Although it was unremarkable, it was nothing really happened. But the case report was a 9-year-old male, and he had a confirmed genetic marker for acute intermittent porphyria and presented for a right inguinal hernia repair. Clinical signs on admission included a heart murmur and anxiety. The family history was filled with anesthetic complications. One relative died on induction with a barbiturate. An aunt had an acute intermittent porphyria episode while under anesthesia, necessitating alkaline heme treatments, and the patient's mother had nearly died during an anesthetic for cardiac surgery. So the preoperative preparation included reviewing the medications that are safe for acute and intermittent porphyria patients. They wanted to minimize the known triggers such as fasting and stress, and they ensured access to the rescue heme medication. Intraoperative management included a propofol induction with the patient's mother present in the operating room, and then they performed an ultrasound-guided ilioinguinal iliohypogastric nerve block under general anesthesia. The surgery proceeded without complications, and the patient did not demonstrate any signs of acute intermittent porphyria crisis. So continued. This was also from the case report. It stated that while regional techniques in acute intermittent porphyria patients have been reported in the literature, there wasn't very much literature out there about ultrasound-guided regional anesthesia in patients that have acute intermittent porphyria, specifically pediatric patients. So in summary, in the case report, they basically presented a successful general and ultrasound-guided regional anesthetic course in a high-risk pediatric acute intermittent porphyria patient. They followed the careful selection of safe perioperative and rescue medications. They used a liberal fasting policy and preoperative administration of dextrose-containing IV fluids and vigilant minimization of other potential acute intermittent porphyria crisis precipitants. More specifically, gabapentin and hemin were ordered and available in the pharmacy in case of a crisis. The patient was encouraged to drink clear white grape juice until 2 hours prior to the surgery. And then on the recommendation of the metabolism and genetics, the patient received an IV catheter in the holding area, and an infusion of D10 and half saline was started. A comprehensive metabolic profile was checked to rule out an appropriate secretion of ADH, and the lab values were within the normal range. And then preoperatively, instead of giving them oral midazolam, they gave them IV fentanyl for mild sedation and administered prior to transporting them to the operating room. Like I said in the last slide, the IV induction was used with propofol, and they placed an LMA. Maintenance was upheld with inhaled sevoflurane, and then under general anesthesia, they performed the right-sided ultrasound-guided ilioinguinal iliohypogastric nerve block. They used a Sonosite S probe and our Sonosite S ultrasound machine, and they used a curved linear probe, and they had clear visualization of both nerves. And they used 4 cc's of 0.25% bupivacaine with 1 to 200,000 of epi. As far as the D10 and the half normal saline infusion, it was continued intra-op, and they checked his glucose, and it stayed within normal range. They kept his temperature between 36 to 38 degrees Celsius, and then they gave 1.5 milligrams of IV morphine bolus prior to the initiation of the surgery. Uh, Zofran 4 milligrams IV was administered during skin closure, and to minimize the stress of emergence, they removed the LMA deeply. They stated that the patient's MAC level, he was at 1.3 MAC. And they obviously ensured that he was breathing spontaneously with adequate tidal volumes at 5 to 6 cc's per kilogram. And they placed an oral airway to maintain patency. And then they followed up by saying the patient was transported uneventfully with supplemental oxygen delivered via Mapleson circuit to the PACU, where he emerged safely. The patient received a total of 2 1 milligram boluses of IV morphine over the following 15 minutes for pain, and there was no acute intermittent porphyria signs or symptoms experienced by the patient, and his vital signs remained stable throughout the PACU, and he was discharged home within 2 hours. They did follow up with him within 72 hours from the surgery and determined that the child never experienced any other type of acute intermittent porphyria signs or symptoms. So this case report pretty much shows us that as long as you follow the guidelines of not giving these patients drugs that are known triggers, you can safely perform anesthesia on pediatric patients with this. And this is just our reference slide.